I'll be speaking on our paper of our experience of Pythium keratitis, a clinical diagnostic dilemma and challenges in management. No financial disclosures. So, what are the existing challenges in Pythium keratitis? It's a rare entity which has been in upsurge in recent years. Clinically and microbiologically, it mimics fungus, hence the diagnosis is delayed. The specific diagnostic method or tool available is only DNA zoospore identification, hence the diagnosis is usually delayed. And it is resistant to all antifungals and has poor outcome with therapeutic penetrating keratoplasty, so the treatment is usually delayed. In the introduction, Pythium insidiosusum is a oomycete, also called as parafungus, closely resembles fungal keratitis. The purpose of our study was to analyze the demographic profile, clinical diagnostic features, challenges in management and treatment outcome. Study design was a retrospective study done during the period of October 2018 to December 2019. 28 Pythium keratitis subjects were recruited at a cornea clinic. Culture proven Pythium cases were analyzed for demographics, visual outcome, risk factors and clinical features. During the study period, 2039 corneal ulcers were recruited. Out of them, 1003 were culture negative cases, 847 were fungal keratitis, 161 cases constituted bacterial keratitis, and 28 Pythium cases we had, which constituted 1% of the total culture positive cases. Inclusion criteria: all clinically appearing Pythium cases who were culture positive were included. Clinically fungal keratitis cases which were culture positive for Pythium later on were also included, and button culture positive cases post therapeutic keratoplasty. In the exclusion criteria, all clinical Pythium keratitis cases but who were culture negative were excluded, and all other infective and non-infective keratitis cases were excluded. We used this diagnostic algorithm for our study. All the cases of Pythium keratitis underwent smearing and culture, and before the culture results were available, all patients were given antifungal. In the culture positive group, if the ulcer size is small, less than 4/4, patients were treated with monotherapy of linezolid 0.2% hourly. And if the ulcer size was greater than 4/4, they were given a dual therapy of linezolid plus azithromycin hourly. If there was good response, the same treatment was continued, and if the response was poor, the patient underwent TPK. In the culture negative group, if the ulcer size was small, they were treated with monotherapy of natamycin, and if the ulcer size was larger, they were again given natamycin plus itraconazole or voriconazole combination. If there was good response, the same conservative management was continued, and if there was poor response, patients underwent TPK, and post TPK, if the button culture was positive, they were treated as anti-Pythium drugs. Coming to demographics, about 20 patients were within the younger age group, less than 50 years of age, 60% were males. Demographic and clinical profile, 13 patients were farmer. In the risk factor, most common risk factor was injury, 22 patients had trauma. Presenting visual acuity less than 1/60 was present in 16 patients, and the presentation lag less than 10 days was present in 15 patients. In the clinical features, most common clinical feature was stromal infiltrate with hyphated edges, followed by subepithelial infiltrate, corneal melt, peripheral furrowing and tentacular projection are specific features, and hypopian and entry chamber exudates were present in 13 patients with endothelial plaque in 18 patients, closely mimicking fungal keratitis. These are the few clinical images. First image shows a tentacular projection of ulcer margin, which is a hallmark of Pythium. Second shows the peripheral furrowing and gutter formation. Third, they have a tendency to spread towards the lumbus, separates it from fungal keratitis. Fourth image shows the whitish plaque infiltrated with hypopian, which is a close mimicker of fungus. Coming to treatment detail, before culture results were available, 14 patients were given natamycin with voriconazole, and 7 patients were given natamycin itraconazole combination. After culture positivity, all patients were added with linezolid, the drug of choice, and 18 patients were added with azithromycin. In the treatment outcome, since due to the virulence of the organism, 19 patients underwent TPK, 5 patients healed with medical treatment, 6 patients had graft reinfection which required a further TPK, and 4 patients were lost to follow-up. Average time to therapeutic keratoplasty was 11 days, and adjunctive measures like glue with bandage contact lens was used in 2 patients and tarsorrhaphy in 4 patients. These are the few images showing recurrence of graft infection. First image shows the peripheral exudates, the occurrence of in the host margin, and the second shows the clump of exudates in the entry chamber. Coming to complications, 50% had choroidal detachment followed by graft infection, retinal detachment, end of. There was no case of evisceration in our study, which separates our study from other studies, and 75% patient we were able to salvage the globe. 3 patients had phthisis and 4 patients were lost to follow-up. Most of the patients have very less visual outcome was very less. PL positive to hand movements were present in 15 patients, and average healing time was 80 days. Comparison of outcome group, 5 patients healed with medical treatment, 19 required surgical intervention. Presentation lag in days and average infiltrate size was more in surgical treatment group, and the average healing time was also more in 71 days. Comparing neck to neck, there was no statistically significant difference between the two groups. So what were the predictors of poor prognosis? Poor presenting visual acuity, early TPK requirement, recurrence and graft reinfection, or was statistically significant for predicting the poor prognosis. Coming to the discussion, our study at 28 eyes, which was the third largest data, patients who required TPK, 70% patient underwent TPK, which is comparable to other studies. Around 20% patient healed with medical treatment. 22% patient required a further TPK. There was no evisceration. All other data shows some of the other patient had evisceration, but our patients had no evisceration. Globe salvage was slightly higher, 75%, and there were 3 cases of phthisis. So what are the take-home messages? Pythium keratitis is more prevalent in younger age groups, majority being software and students. Most common clinical finding is stromal infiltrate with hyphated edges, and the specific clinical finding we should look for peripheral furrowing and tentacle. TPK is the treatment of choice, as in our study 70% patient needed a TPK, 20% patient healed with medical treatment. If managed conservatively, aggressively, globe salvage rate is high, 75% patients we were able to salvage, and there was no evisceration. Early diagnosis, targeted meticulous management, and regular follow-up are the key for managing these cases successfully. Thank you.